National Education Conference. Welcome to Florida, and we hope that you're going to enjoy your next 3 days of education and support and camaraderie. Without any further ado, I'm going to introduce our speaker this afternoon. Dr. Mark Brantly is Chief of Pulmonary Medicine and Professor of Medicine at the University of Florida. He also serves as the Alpha-1 Associate Director of the University of Florida's Clinical Research Center, and he's Director of our Alpha-1 Research Program. He has helped expand detection and screening programs and free confidential testing services. And he's here to talk today about the Alpha-1 protein in normal healthy and how Alpha-1 deficiency affects the lungs and the liver. And do we have some first-time attendees in here? Okay. Just like to let Dr. Brantly know that we have some of you. We're really pleased to have all of you. So without any further ado, Dr. Brantly, turn it over to you.
Kathy, thank you very much. Let me give you just a little preparation. I don't talk down to people. This is the same lecture I give to medical students in a lot of ways. And so you're not expected to know it all right away. The way it comes, particularly for the newbies, is that it takes you a while to get it. You'll go back and see that these will be posted on the websites to talk about and such, and you'll learn it, I assure you do. Knowledge is power. I feel very strongly about that. And what I'm going to do is give you a background about alpha-1 antitrypsin deficiency and go for it. So first I'd like to talk about conflicts of interest. I think that's an important thing to know where I come from. I do receive research funding from the Alpha-1 Foundation, the National Institutes of Health, Baxter Biologics, Telecrest, Cometa, and I don't receive any direct funds from anything because I'm not rich. I drive a minivan. All the monies go to the university, and I'm a special consultant to the FDA, and the things I'm going to talk about don't necessarily reflect the FDA's opinion regarding this. So our major objectives are to learn about the clinical and molecular features of alpha-1 antitrypsin deficiency, to learn who should be screened for alpha-1 antitrypsin deficiency, because that's one of the major themes for this particular conference, and then learn about new and current therapies. And I will do as much as we have time for that, because there's a lot of things that are happening right now. And we're also going to have some more research talks later on in the program as well. So this is a first relatively dense slide. I believe in the thing you tell people what you're going to tell them at the beginning, and you tell it and go through it again. So this is a CAT scan, a coronal section, slicing somebody straight like that, of an alpha-1 antitrypsin deficient individual who actually also has a rare disorder called antithrombin 3 deficiency, where people have a tendency to clot as well. Unfortunately, he passed away about 4 years ago now, but he was unable to receive augmentation therapy because his veins would clot all the time. He has emphysema that's predominantly in the lower lobes, but it's a little bit patchy. So what are the clinical features of alpha-1 antitrypsin deficiency? Number one, they're characterized by low alpha-1 antitrypsin levels, about 5 times less than normal individuals. It's characterized by a single gene mutation almost 95% of the time. Okay? So it's not like cystic fibrosis where there's thousands of mutations. Alpha-1 antitrypsin has hundreds of mutations, but the vast majority of those mutations aren't associated with disease, and most importantly, the one that affects most patients is a single gene mutation. And the gene mutation, we call it PIZ. It's a substitution of a building block of amino acid called glutamic acid to lysine and amino acid 342. It's a single change in a base in a string of DNA bases that are more than 14,000 long. So a single change. We know that people that have a risk ratio, MM, which is the normal alpha-1 antitrypsin type, is associated with background or 1. We talk about risk. So that's normal. People that are carriers have a 1.5 to 3-fold risk of developing lung disease. People that are SZ have about a 4 to 8-fold risk. And people that are alpha-1 antitrypsin deficient, fully deficient ZZ, have an 18-fold increased risk of developing lung disease. The clinical presentation of alpha-1 antitrypsin is quite varied. Asthma, bronchiectasis, which is a bronchial tube damage that occurs and something can bring up sputum, pneumonia, COPD, and cirrhosis. It's oftentimes, once it develops, associated with a rapid decline in lung function over the time. And obviously, many people know here, it can be associated with premature disability and death as well. I just saw a patient in my clinic on Wednesday who's 88 years old. He came to me 1 year ago complaining that he couldn't golf a whole 18 holes any longer. And he has alpha-1 antitrypsin deficiency. His lung function is about 65% are predicted. There's a huge amount of variability, and one of the things I'm going to make as a theme is there are many environmental factors that play a role in lung damage. And our goal is to try to avoid those and keep ourselves healthy over time. So let's talk about Alpha-1. Number one, it's one of my favorite molecules. You can't imagine that it is. It is a remarkable molecule in a lot of ways. This is a cartoon of what the alpha-1 molecule looks like in 3 dimensions. What we do is we take alpha-1 antitrypsin, we crystallize it, so it's in crystals, and then we take X-rays and we bombard it. And where it hits an atom, it bounces off, and it gives us a negative picture of the 3-dimensional image. And so it's important so you can see what that looks like. This is the reactive site loop right here that sticks out into space. What I've taken off are the sugar molecules because it's a glycoprotein. It's an acute phase reactant anti-inflammatory molecule, and we'll talk a little bit more about that as we go forward. What does acute phase mean? When you have an infection, that particular protein goes up. It's secreted in large amounts by hepatocytes, but it's also made in other tissues as well, including monocytes or macrophages, even made in your gut. 99% of the alpha-1 antitrypsin that circulates in our bloodstream is from the liver, though. There are at least 100 different alleles of alpha-1 antitrypsin, so we're going to learn a little bit of nomenclature. Alleles are basically the same copies of the alpha-1 antitrypsin gene on your maternal and your paternal chromosome. Most of us have 2 chromosomes, and you can have one normal one and you can have one abnormal allele. Okay, there are about 34 to 40 alleles that are associated with deficiency and dysfunction. These mutations can affect either the amount of alpha-1 antitrypsin that gets pushed out into the bloodstream, but it can also affect its function as well. So it doesn't work as well as an inhibitor of neutrophil elastase and other things. The frequency of the Z allele suggests a selective advantage. We know that cystic fibrosis, we think there's a selective advantage. Sickle cell anemia, there's a selective advantage. What is a possible selective advantage of having alpha-1 antitrypsin? Anybody know? Well, there are 2 ways to have selective advantage, actually. Maybe more than that, but 2 major ways. One is that it confers resistance to a disease. Sickle cell, if you're a heterozygous, you don't get malaria as often. For cystic fibrosis, we're almost positive now that it confers a decreased risk of dying from cholera. But having alpha-1 antitrypsin deficiency doesn't seem to confer any kind of health benefit. But it does have a potential benefit that might cause it to be more frequent in the field, and that is that there's a fertility advantage of being alpha-1 antitrypsin deficient. How could that possibly be? Well, actually, proteases are necessary for burrowing into the zona pellucida of an egg. And the protease that's used is inhibited by alpha-1 antitrypsin deficient. And there is a tiny increase in the number of fraternal twins and fecundity of women that are alpha-1 antitrypsin deficient. So it wasn't you guys, it was the women. That make us. I just want to point that out. So that hasn't been 100% proved, but in animal models it's been shown to be true. There are mice, you can make them deficient, their litters will get bigger and the such. I don't think we'll be doing any experiments in here about how many babies you want to have. Okay, so let's talk a little bit more about genetics for a moment. Now, probably everybody knows this. Insanity is hereditary. You get it from your kids. Now that I have a 16-year-old daughter, I can tell you it's getting more tough by the day. Alleles are the result of genetic variation on the same gene. Not all genes are associated with disease. In fact, the vast majority of allelic differences are not associated with disease. It's an important thing to think of. So when you talk about mutations don't mean slime arising from the swamp. Mutations are a natural part of life and how we actually improve ourselves, how we improve ourselves as an organism. Every single person in this room and in the world has what's called a genetic load. Genetic load means you have between 5 and 15 genes that may be associated with your death or disability. The difference between you and I is you know about one of yours. I don't know about mine. And that's a good thing because we know that there are environmental interactions with most genes. And so if you can avoid some of those environmental interactions that trigger more lung damage, more liver damage, and that kind of stuff, then you're better off. Genes are not absolutely predictive of the development of disease. Remember my 88-year-old with alpha-1 antitrypsin deficiency. So it's not written in stone, you have this and you will go. The phenotype, the characteristics of alpha-1 antitrypsin deficient individuals is incredibly varied. It's as varied as the people in this room here. The risk ratios we talked about. So let's talk about more of the epidemiology of it. It's a relatively common inherited disorder. About 1 in 2,500 to 1 in 4,000 individuals in the United States have alpha-1 antitrypsin deficiency. If you go back and look at the gene frequency among COPD patients, we estimate there's between 100 and 200,000 individuals in the United States that are heterozygous and probably 2 or 3 million individuals that are carriers for alpha-1 antitrypsin deficiency. The most common clinical features are COPD and liver disease. There's associated with a rapid decline in lung function, oftentimes associated with lung infections. One of the characteristic histories I take from my patients is, Doc, I was fine until I got that pneumonia and I never got better. And that's an important feature that tells me that we need to look for alpha-1 antitrypsin. Asthma is a very common presenting feature. And that's oftentimes patients will spend time in an allergist's office saying, I can't understand why I'm so short of breath. And then they'll discover that they have COPD and alpha-1 antitrypsin deficiency, and probably an asthma component as well. It is the most common. Carriers are at increased risk, as we talked about, and that's an important concept. In the big scheme, I know you guys think you're so special, but actually, heterozygous individuals are the major healthcare problem that we have because there are millions of them, and they have disease. It is the most common inherited risk factor for chronic obstructive pulmonary disease. We've been searching for genes associated with COPD. The major one is alpha-1 antitrypsin deficiency. Early diagnosis and preventative care we know translates into health benefits, and that's one of the things that'll be another theme. In the state of Florida, about 900 individuals die of COPD every year. 9,000 of these individuals, 900,000 individuals with COPD, 9,000 die, and about 900 to 1,000 of them are carriers for alpha-1 antitrypsin genes. So that puts it into a very individual thing, and we want to do that. Unfortunately, the vast majority of people are not diagnosed. Alpha-1 antitrypsin is a laboratory diagnosis. It is not a clinical diagnosis. It is not a clinical diagnosis. A doctor can't look at you and say, you have alpha-1 antitrypsin deficiency. They'll be wrong almost all the time, except when you have severe classic disease. And in fact, one of the things I teach my medical students and residents is that in medicine, the classic presentation is rarely the common presentation of a disorder. And that's the reason why we have to teach our physicians to look for alpha-1 antitrypsin deficiency in non-classical situations. It's the fourth leading cause COPD is the fourth leading cause of death in the United States. In the decade, it'll be the third leading cause of death in the United States. There's at least 24 million individuals that have impaired lung function, many of them undiagnosed. And there's almost 200,000 deaths, 100,000 deaths in 2002. And of course, that's gone up quite a bit. And again, Alpha-1 is the most common inherited cause. We estimate that at least 10,000 people in the United States die with alpha-1 antitrypsin deficiency every year that we don't know about. So how do we identify people? Well, number one, the doc has to think about it. And you guys can be the advocate. You know how doctors think about how to do things? I guess you're wondering, really. We actually are people, individuals. We think about things in terms of cases. We learn about something and we never forget about it. The way we go around and we teach young physicians is we present cases that have a classic presentation, and we talk about that particular individual, Ms. Jones, and say, this is what they have. If you have alpha-1 antitrypsin deficiency, your doctor will not forget that. They will not forget that. And if they do forget it, you should be reminding them. Because that's how we learn things. That's how we remember things, is by cases. All individuals with chronic obstructive pulmonary disease should be tested once by PI typing and genotyping in an alpha-1 antitrypsin level, and we'll talk a little bit more about that. All individuals with asthma and a non-reversible component should be tested for alpha-1 antitrypsin deficiency. Family members of individuals identified with alpha-1 antitrypsin deficiency should be tested. And in individuals with cryptogenic cirrhosis, people that it's not clear why they have cirrhosis, should be tested as well. So let's talk a little bit about some of the functions of alpha-1 antitrypsin. And I'm going to start with the most simple functions, okay? Because it ain't that simple any longer. We've learned a lot. Alpha-1 antitrypsin, you see this little turtle right here. It has an active site called methionine 358, which interacts with an omnivorous protease. What's an omnivorous protease? Omnivorous. It eats everything. It's like Mikey. It eats everything. Neutrophil elastase gobbles up everything. Neutrophil elastase interacts, when it's not gobbling, can interact with alpha-1 antitrypsin, and they bind together in a suicide pact which takes out the function of neutrophil elastase, so it can no longer destroy tissue. And that's one of the major functions that we think alpha-1 antitrypsin has, but it has a lot of other functions as well. If we were to take a picture of the lungs of all people that have alpha-1 antitrypsin deficiency and compare it to a normal person's lungs, what we'd find is in a normal individual, there's very little in the way of neutrophils, and hence neutrophil elastase in their lungs, destructive enzymes in their lungs. And they'd have an overwhelming amount of alpha-1 antitrypsin in their lungs to protect from damage. In people that have alpha-1 antitrypsin deficiency and start to develop lung disease, they basically have an increased amount of neutrophil elastase in their lungs and neutrophils, and they have very little in the way of alpha-1 antitrypsin as well, and so they develop disease. So lung damage is a result of both increase the number of neutrophils as well as a lack of alpha-1 antitrypsin in there, and so it's important that both those things play a role. Now, so it's not so simple, and so I'm going to present you this sort of table which tells you a little bit about how I think about and how my colleagues think about alpha-1 antitrypsin deficiency. I think of it as an initiation stage for lung damage. I see it as a propagation and maintenance phase where things get ramped up and worse. And I see it as when those things get ramped up, that there are effectors of injury. Now, why is that important to think about it? Because these are the ways we treat alpha-1 antitrypsin deficiency right now in 2010. Well, we try very hard to get people to quit smoking. Very, very hard. In fact, in my clinic, I have a quit rate of 95%. You know what the average quit rate is? It's 20%. Why do I have people quit? Because I have my nurses bug my patients to death until they quit, because of all the things that I can do to prevent damage or to keep my patients healthy is to get them to quit smoking. Cigarette smokers die 20 years before non-smokers do. 20 years. I mean, that's a huge amount of time. So I invest a lot of time in getting people to quit smoking. And I beat on them. I do whatever I can to do that because I know it's not an expensive therapy that's going to make the difference. It's going to be quitting smoking. Infections play a big role. So we do treatments that center around infections. Polymers of alpha-1 antitrypsin, Z can stack on itself, and we'll talk a little bit more about that, can also cause inflammation in the lung. And there's a new concept that's emerging that suggests that misfolding of the alpha-1 antitrypsin protein actually also causes cell injury as well. We'll talk just a tiny bit about that, not a whole lot, because that's pretty complicated. But these initiation factors basically drive our immune system to ramp up inflammation in your lungs. Okay? These inflammatory cells invade the lungs. They release biological substances that recruit even more stuff. And some of these cells release injury things like oxidants, proteases, and alpha-defensins. Now here's the amazing thing. Alpha-1 antitrypsin doesn't just inhibit proteases. It inhibits these defensins and oxidants as well. It's a broad-spectrum anti-inflammatory molecule. Remarkable. The great maker, the great biochemist and geneticist in the sky, was very clever in making this protein the way it was made. It basically is a protein that's approximately 90 million years old, so it's had a lot of time to sort of improve itself over time. This injury can be in the lungs and airways. So it's important to imagine that it's not just an antiprotease. It is an anti-inflammatory molecule. Does everybody get that? Because if you're going to understand some of the things about new therapies that are going to come in, you have to understand it's an anti-inflammatory molecule. That's one of its major keys. It inhibits a neutrophil defensin, which is this small molecule that looks like a Klingon bird of prey that basically punches holes in our cells as well as viruses and fungi and many other things as well. An important biodefense against infections, but also can be turned against us. And alpha-1 antitrypsin inhibits that, absolutely. It also has these amino acids that suck up oxidants as well. It's a remarkable molecule in that sense. So I like to think of the genesis of lung disease as actually multifactorial. And all of these things, to an extent, play a role in damage. And all of these areas, we're developing new therapies to attack. So let's talk some genetics. Everybody in here except for Kathy has chromosomes. She just left, so I said things like that. So, and we have 2 copies of each of our chromosomes, one from mom, one from dad, or in case of my children, one from an alien and one from mom. Alpha-1 antitrypsin is located on the end of chromosome 14 where the immunoglobulins locus is. Immunoglobulins are the things that help protect us from infections. It's in a cluster of genes that are very similar to itself. So what nature does, it says, this is a good theme, I'm going to duplicate it and make some changes in it. And it makes a whole cluster of different genes that are made. These are protease inhibitors up here, and this is cortisol binding globulin right here. The alpha-1 antitrypsin locus is called PI. It's also called serpin A1 or clad A1. These are all the terms sometimes if you're doing searches on the internet that you come up with as far as the name. The PI locus transcribes a 14,000 base pair gene that's split. These areas are responsible for giving the information about the building blocks, the amino acids for protein. And these areas actually play a role in probably telling the protein how to fold and the such. This protein, this gene, is transcribed into a message which is in the nucleus of the cell, which is then transported out into the cellular machinery to make a protein building block. And so it looks like this at this point, and it's around 1,200 bases long. There are a lot of normal genes. Remember I told you earlier that a genetic variation is not a bad thing. And in fact, if you look at some of the reports that I send out from our laboratory, you'll see numbers like M1, M2, M3, M4. There's an M5, there's an M6. All of these are associated with just variation in alpha-1 antitrypsin deficiency, alpha-1 antitrypsin molecule, but does not cause any kind of disorder or disease. There are, of course, a lot of genes associated with alpha-1 antitrypsin deficiency as well, though. There are some very rare ones that collect down this area. Do you think this might be an important area of the protein? Absolutely. That's an important area of the protein. The alpha-1 antitrypsin most common allele, the Z gene, glutamic acid to a lysine, is down here near the end of here. But there are a whole bunch of these, and I've made my career as a geneticist basically defining these and understanding them better. It's helped me understand the alpha-1 antitrypsin molecule better as we talk about doing engineering of the molecule as well as figuring out how to make it not misfold appropriately. In fact, there's another class of alpha-1 antitrypsin genes that are associated with no alpha-1 antitrypsin at all. We call those the null alleles. They have some really incredible names like Bonnie Blue, Trastevere, New Hope, all these things. And they're named after the oldest member of the family that has that particular abnormal gene in their family. And so I have the opportunity to do that, and name these very strange cities like Clayton, Null Hong Kong, etc., etc. This is what the alpha-1 antitrypsin protein looks like in 3 dimensions in a different type of cartoon. And we're going to go over this in a little bit more detail. Here is the active site. The active site interacts with the protease, neutrophil elastase, and other proteases as well. It's on a loop with like a tight rubber rod, and it's under a huge amount of tension. When it interacts with neutrophil elastase, it clips it right there, and it's like a spring. It basically almost stabs the neutrophil elastase and locks it into place so that it can't be taken out. The alpha-1 antitrypsin gene mutation most commonly associated with disease is located right here at the hinge area. And that hinge area is very, very important in health also. So if that hinge area is damaged, it makes it so this does not interact very well with alpha-1 antitrypsin. But it has another consequence as well. It misfolds in the cell, and it's destroyed. And it also can accumulate in the cell as well. And we'll talk a little bit more about that as well. Indeed, what can happen is the alpha-1 antitrypsin protein, the Z molecule like that, can actually dock into another Z molecule, forming these concatemers or polymers inside of cells. These are not available to inhibit neutrophil elastase or protect you. And there's a thought that they may actually injure the liver as well. And there's some evidence that suggests that it may attract more inflammation. So what happens is these alpha-1 antitrypsin concatemers form these globules in the liver. This is an electron microscopy. We're looking at a very, very high power. You get this amorphous material, and you can actually see these serpentigenous things that are chains that form the Z alpha-1 antitrypsin. Dave Lomas described this earlier on. What can happen then is you can get a cirrhotic liver. Normally, livers are supposed to be nice and smooth. But they develop these fibrotic panels. They're supposed to be really, all the liver is supposed to be like this and not in these little islands like that. They can have these globules full of material, and that's staining for alpha-1 antitrypsin, so it gets stuck in it. But alpha-1 antitrypsin is not a storage disease like glycolytic storage disease or anything like that. The vast majority, 95% of alpha-1 antitrypsin is rapidly degraded. We have quality control machinery that basically says, this is a crap molecule, let's destroy it. And it's a conservation, a very important thing that we have to do from that standpoint. So let's talk now about the spectrum of lung disease. So let me start with the first thing. You can have alpha-1 antitrypsin deficiency and not have any lung disease whatsoever. That's one spectrum. We can also have have normal lung function and have evidence of emphysema as well. So the tests that we use to determine whether somebody has lung disease have their different specificities. CT is very, very specific, and that's the reason why often your physicians will order one to characterize the amount of alpha-1 antitrypsin, amount of emphysema you have, the amount of bronchiectasis you have, amount of airway damage, because it helps us tailor your therapies in the future. We also look for giant bullae, which possibly can be taken out. We do not do LVRS, lung volume reduction treatments on alpha-1 antitrypsin deficient individuals. And if anybody try to talk you into that, run away from that doctor as fast as you can. Because there's great evidence that people basically not only don't get help, but they actually have an increased risk of dying when they have it. So it's very important. It's not like garden variety COPD. We talked about infections. What's bronchiectasis? A lot of people ask about it. Does anybody in the room know about what bronchiectasis is? Oh, come on. Charlotte knows. So bronchiectasis, normally our air tubes, we have a series of defensive mechanisms in our lung that keep us from dying. They fall into three major categories. One is anatomical. The other one is humoral. We have antibodies that fight infection. And then we have a cellular system that basically picks up bugs and eats them. The anatomical system is really, really important. We breathe about 10,000 liters of air a day. And if you look on your dashboard, there's a lot of crap in the air. But amazingly, if we were to breathe it every day, we would think that we basically were succumb to all this garbage in there. But we have systems that bring it up. Our airways taper, so things tend to hit on the side. We have mucus that picks it up, and we have hairs that sweep it up. It's a key thing. When people have chronic damage in their airways, they actually lose the supporting structures of the airways. And the airways don't taper any longer. They lose the hairs, and they actually make too much mucus. So they start coughing up stuff. Sometimes they can cough up blood, that kind of thing. So you think, well, I don't have this. When we do CT scan studies, about 95% of alpha-1 antitrypsin deficient individuals have focal areas of bronchiectasis in their lungs. Okay? It's not like cystic fibrosis, which is a classic example of bronchiectasis. You have milder, but most individuals have some bronchiectasis. We know about the asthma. We've talked about it. One of the other features is that alpha-1 antitrypsin deficient individuals can have an accelerated rate and decline in lung function. What does that mean? Okay? We all lose a little bit of lung function every year. We lose about 20 mLs or about not quite an ounce of lung function per year. When you have alpha-1 antitrypsin deficiency, you're characterized by a more rapid decline in lung function. And if you're in the FEV1 strata of 35 to 80% of particulate, you lose about 83.5 mLs per year. Why are these things important? It's one of the reasons why doctors follow you with lung function. Like, why does that doctor do all those things? Well, part of it's to make lots of money for the hospital. But there's actually another reason, and that's to follow your status and maybe intervene if they need to. We also know that lung inflammation begins early on. I've done a study in which I've lavaged people that were really, really young, and they were already starting to develop some inflammation. And so we know that that process can start early. So we think of alpha-1 antitrypsin as an emphysema, but it's not just emphysema, it's airways disease. And it's important because we have drugs that we use to treat the airways disease, and they're important to take. As I mentioned, CT evidence. There's actually some evidence in animal models that if you give inhaled alpha-1 antitrypsin deficient, it actually raises the threshold for them being stimulated to develop asthma. And there was a survey done by Dr. Lieberman from California some years ago, which some of you may have participated in, that showed that people that were on augmentation therapy had less asthma symptoms as well. So we know it affects the airways. Now let's talk about the phenotype. I wrote this paper. It's published in 1988 in the American Journal of Respiratory and Critical Care Medicine. And it said that this is the features of alpha-1 antitrypsin deficiency. It's bullshit. It's bullshit, I didn't know it then, but it's not true. The features of alpha-1 antitrypsin deficiency are anything you can possibly imagine. It doesn't take a rocket scientist to identify somebody that's age 35, that's been smoking for 20 years, and has black lungs and is really short of breath. That's not, that diagnosis is obvious. My 13-year-old son can make the diagnosis of alpha-1 antitrypsin based on that. But that's not where we want to be. We want to be where we make the diagnosis for people who develop disease. And that's the reason why family screening is so important. Because if we can identify people early on, we can help them change their lifestyle, not smoke, and many, many other things. So when you read about this stuff, it's not true. Yes, can people have these kinds of things? Absolutely. We'll talk more of that. We'll talk about the GI symptoms of alpha-1 antitrypsin deficiency more in this conference, and we'll also talk about rare manifestations as well. In that same article, I wrote this incredible thing too. This is called a Kaplan-Meier life table, and it shows that only 16% of alpha-1 antitrypsin deficient individuals with lung disease were alive at age 67. That's not true any longer. It's not true any longer. This is an example of doing studies on people that already have a disease. As we have done more studies looking at the whole alpha-1 population, we began to realize that having alpha-1 antitrypsin deficiency is not a death sentence. That's important for you to understand, because you shouldn't be getting out of your insurance right now. Or doing something wild that you might be embarrassed about in the future, because you're probably going to be around a lot longer than you think you are. When people do die, they do die of breathlessness and emphysema, infections, sepsis, and liver disease. All alpha-1 antitrypsin deficient individuals have a lifelong increased risk of developing liver disease. And it's important that need to be monitored over time. So how do you make the diagnosis of alpha-1 antitrypsin deficiency? It is not a clinical diagnosis. It's a laboratory diagnosis. It's made by pricking your finger, drawing your blood, getting a buccal swab, something like that, of DNA or plasma, something like that, to make the diagnosis. And it requires a synapse in your doctor's brain thinking, gee, I think this patient may have alpha-1 antitrypsin deficiency. We do genotyping. That's one way we do it. We actually look at the single base changes. That's a fast and easy way. My lab has now genotyped 80,000 patients for alpha-1 antitrypsin deficiency. You can do PI typing, and we'll talk a little bit more about that. It's also sometimes called phenotyping. We measure alpha-1 antitrypsin levels by nephlometry. It's a clinical machine which can process lots of plasma samples. We measure all sorts of things. When I first started cloning genes and such, when the dark ages, it took me 2 to 3 years to identify a mutation in a gene. Now people in my lab do it in an afternoon, and sometimes even faster than that, a couple of hours. So that's how much things have changed in the last 20 years as far as doing that. We can do it on many different types of things, and we are in the process of developing point-of-care test systems as well, so that you'll be able to have them in your doctor's office and actually be able to get tested straight away. So let's talk about some of the stuff. And by the way, if you don't get this now, I brought my whole lab down for tomorrow, and they will be happy to tell you everything you ever wanted to know about genotyping, phenotyping, levels, whatever you want. It's going to be show and tell. They love doing that, and please go by and talk to them. So we take a spot of serum, we put it on this thin gel, and we separate alpha-1 according to its charge. Proteins have mass, weight to them. They have size, and they also have charge. And the reason why they have charge is because amino acids can be positive, neutral, or negative. In this particular case, when we put a high charge, the proteins separate out into these patterns like this. And here is a ZZ individual at the far end right there. That sort of means faint, and it actually migrates in a different place. This is MM, the normal one. And here's a carrier right here. We do these gels every single day at the University of Florida, every single day, to look at this. And so when you get these reports back, that's what it is. So you can sort of think, what does MZ mean? This is what MZ means. Okay? The alpha-1 antitrypsin phenotype, or PI type, dictates what the alpha-1 antitrypsin level is. So here, this box is the normal range. And in normal individuals, it's from 20 to 50 micromolar, or about 110 milligrams per deciliter to about 300 milligrams per deciliter. Carriers can be in the abnormal range or in the normal range. And that is the reason why you can't use alpha-1 antitrypsin levels to detect them. You have to use a more advanced test, like either phenotyping or genotyping, to identify these individuals. ZZ individuals are about 5-fold less, and here QO, which means what? No. God, you guys are brilliant. You're smarter than the medical students are, I want to point out. That's very good. So they have no alpha-1 antitrypsin whatsoever. This is a typical pedigree of alpha-1 antitrypsin deficient family. We're going to focus on generation 2. And as everybody in the world knows, men are square and women are round. And so here is daddy, there's mommy. They have normal alpha-1 antitrypsin gene, M1 and M2. And this is the frequency layout that they might have. 50% of the individuals will be heterozygous, MZs. 25% will be entirely normal. And 25% of them will be ZZ. Okay, how do you explain that a family is all ZZ, or all normal, or all heterozygotes? Because it's a roll of the dice. Now, if some of you women want to do an experiment and have 100 babies, I guarantee you it'll come out probably 25% will be ZZ. Anybody volunteering? Okay, I didn't think so. Trust me, it's true. So how do you treat lung diseases, okay? And I'm going to treat this the way I do a consultation in my office when you come to see me. This is a situation that we know goes on in people that have lung disease. They have an increased amount of neutrophil elastase and neutrophils in their lungs. And they have a decrease in anti-neutrophil elastase protection in the form of alpha-1 antitrypsin. So there's two major approaches to it right now. Augment the alpha-1 antitrypsin levels. We can do that by replacement therapy, and there are a number of other supporting. Or we can reduce the burden of neutrophil products. Okay, what's the first thing that will reduce neutrophils in the lung, inflammation in the lung? Not smoking. Very good. Not smoking. Not smoking. So that's number one. Avoidance of dust and smoke, even passive smoking. What are the things that drive lung disease in alpha-1 antitrypsin deficient individuals? And Niesmeyer did a great study which showed that personal smoking is number one, passive smoking is number two, including your parents. And number three is workplace exposures to dusty environments. Pneumococcal and influenza vaccinations are important. Who in this room believes that getting an influenza vaccine is associated with getting influenza? Great, I'm glad you're not doing that. So don't give me the excuse, I don't want to take my influenza vaccine. Okay? Because it attenuates the disease in many, many people. And I've had too many patients die because they got a pneumonia after having influenza. If you can take a vaccine, take it. Alpha-1 antitrypsin deficient individuals will be first in line when the vaccines come out. You need to be immunized for your pneumococcus every 5 years. And it's important to treat the airway reactivity as well as the inflammation with inhaled steroids and bronchodilators. It's very, very important to do that stuff. Liver disease is not as clear. What are the things that drive liver disease in alpha-1 antitrypsin deficient individuals? Well, we have a lot of research to do, and the foundation is beginning to do a big push to do research in liver disease. We know one major thing is fatty liver. So people that have fatty liver, overweight, have metabolic syndrome, have an increased risk of progressing to liver disease. So it's important to eat right, and as you can see, I eat right all the time. If you have diabetes, keep it in tight control and exercise. The most difficult prescription I send my patients out on is exercise. Exercise, exercise, exercise. We all want to live a long time, but we also want to do whatever we want to. We want to make love. We want to have fun. We want to play with our children. And we want to travel to foreign places, like Orlando. Abstaining alcohol, I don't feel it's necessary, but alcohol in moderation is a very, very important thing. Binge drinking is absolutely a no-no. And alpha-1 antitrypsin deficient individuals, like anybody that has chronic diseases, is at risk. People who have chronic diseases self-treat. And one of the available drugs we have is alcohol. So it's important. Now, how much alcohol should you drink? Or are you allowed to drink? Number one is, you know what the definition of an alcoholic is? Somebody who drinks more than a doctor. Okay. Only kidding. Only kidding. I'm a teetotaler, by the way, so you come to me and it's zero. Some people say to avoid hepatotoxic drugs. I don't necessarily believe that as well. Vaccination for hepatitis B and A seems reasonable. And Dave Lomas, a while ago, supported avoiding fevers and chronic inflammation. And I'm not sure about that either, but there are things that we're investigating. Yes, sir?
The second, explain that.
Okay, hepatotoxic drugs. Okay, Lipitor, methotrexate, all these other things. Okay, let me go back. It's not to panic anybody right now. I don't believe this. Okay, I have lots and lots of patients on, cholesterol-lowering drugs all the time, and I never see problems anywhere above what I see in regular patients as well. So I don't believe in that. Jean, I'm sorry. I was thinking about her.
How about Tylenol?
Tylenol, I think, is safe, but you have to remember, Tylenol is the most common cause of acute liver injury in the United States. So it's not a solution to common pain that lasts for a long time. So you take Tylenol in small amounts as long as you need it and not anymore. Yes, ma'am.
I have a friend who is a pharmacologist. He teaches at Emory in Atlanta. And his specialty is the liver.
Uh-huh.
And he said, if you are going to consume alcohol, never consume a product with acetaminophen. And this is his life's work.
I haven't seen anything published like that, though. And so what I have to say is that I'd be careful. And again, it's always about how much alcohol. Usually we have to triple the amount that somebody says they drink, and that gives you about an accurate amount that they take. So, but I think these are things you need to think about. They're life choices. So what are the therapies available for alpha-1 antitrypsin deficiency? Well, we have pooled human alpha-1 antitrypsin. That's one. The doses, we're exploring different doses right now. There have been no controlled studies per se that have absolutely demonstrated, but there's an enormous amount of evidence that it helps. It is not a magic bullet by any stretch of imagination, and that's the reason why we need new and better therapies. Is there anybody in the room that doesn't want new or better therapy? Okay, so we're working on them. Therapies that are in development include aerosolized alpha-1 antitrypsin. There's been recombinant programs. There's been pooled human alpha-1 antitrypsin, nebulized. There are gene therapy studies going. There are chemical chaperones which allow more alpha-1 antitrypsin to get secreted out of the liver. We're actually developing compounds that prevent polymerization of the protein. And we're also looking at other unique compounds. In fact, there was a publication in Science recently by one of the liver Alpha-1 docs that suggested that there's a biochemical moiety that may also help in decreasing the amount of a cellular process that collects alpha-1 antitrypsin. But first, before we do anything, before we spend a dime on new therapies, before we spend a dime on anything else, early identification is the biggest bang for buck. I didn't believe that. I really didn't honestly believe that. And John Walsh took me kicking and screaming into massive screening. I said, this is crazy. But I've become a believer. I've seen the effects of early diagnosis, counseling, and making a difference from that standpoint. So it really is about screening early. Yes, ma'am?
The problem that we have is children will tell us, well, I don't have any symptoms, so I don't want to risk being tested because they might deny us our insurance.
Well, all those things are real. And this conference is to discuss those things fully. I'm not going to talk about, because there's some experts going to be talking about that. Everything is risk and benefit. Everything we do is risk and benefit. And we need to decide that under the circumstances. And it's one size does not fit all. So you will have to individually decide whether it's best for your children or not. And I think that these will give you some help during this conference in thinking about it, but it's really about risk and benefit. So here in the state of Florida, we've had a program going on for a very long time in screening. We're trying to flip the burg, where we identify most people and we can help make the right decisions and help treat them. We have basically a long time ago established a consensus among the Alpha-1 community that the risk for screening was better than the benefit overall, not for necessarily specifics. We have a high throughput laboratory. We've now screened more than 80,000 patients for alpha-1 antitrypsin deficiency. We have great professional materials provided through the Alpha-1 Association and the Alpha-1 Foundation to talk to physicians as well as to talk to people that are affected with alpha-1 antitrypsin deficiency. And we've been marketing this for a long time. And the Alpha-1 Foundation has established a wonderful referral system for alpha-1 antitrypsin deficient individuals. Here in the state of Florida, we have liver lung transplants, we have genetic counseling, and also we have a specialty clinic. There are specialty clinics in many states right now. And so it's really, really important that if you have the opportunity to go to one of these specialty clinics, sometimes you should go to them. This is the approach we do. It's called targeted detection. We look at people that have established obstructive lung disease. We then screen them for the S and Z alleles, the two genes most often associated with alpha-1 antitrypsin deficiency. If they're positive, we get an alpha-1 antitrypsin level, and then we know what their genotypes are. We always do a second test. Okay, why do we do a second test? Because this changes a person and their family's life forever. So you don't make a decision that's going to change your life without getting a second test. I strongly encourage people to get that second test, to follow up on it. Even if insurance doesn't pay for it. In our case, where we do it under some of these programs, you don't have to worry about that. But it's important to get it done. It is worth your money to do it. Labs make mistakes. Things are more confusing than you might think. And the allelic systems are very tough. So again, going back to screening again, because that's what we're about, is family testing and screening. Individuals with COPD should be screened. All individuals with asthma, which has a non-reversible component. Family members and individuals with cryptogenic cirrhosis at the present time. So, when we talk about COPD management, it's spirometry and alpha-1 antitrypsin testing. Then smoking cessation, pharmacotherapies, and immunize and consider oxygen at the end of things. Thank you very much for your time. A few minutes for questions. Yes, ma'am.
Another question. There are many physicians who have been treating patients with COPD for years and have not tested them on their, they don't, can't hear.
That patients that they song's on. Okay. Testing 1, 2, 3. Okay. So I hear from physicians all the time, I never see alpha-1 antitrypsin deficiency. I said, well, you do test for it? No. Let me emphasize this one more time. Alpha-1 antitrypsin deficiency, the diagnosis of alpha-1 antitrypsin, is not a clinical diagnosis. It's a laboratory diagnosis. You have to prick your blood, squeeze out some saliva or something to make the diagnosis. You can't look at a patient and say they have alpha-1 antitrypsin deficiency. It's not possible to do it accurately. Another question? Is that how do you motivate them to do it? How do you motivate physicians to do things, okay? One is you tell them it's really important to you. The other thing you can do is you can be sneaky. You can say, well, gee, the pulmonologist across town tests for it. Doctors like to stay in a group. They're all things. But the most important thing is, as I told you in the very beginning, we are centered around our patients, okay? We think about you all the time, sometimes obsess about you. And so we think about things according to the patient we've seen. I've seen Charlotte Madison, and therefore I'm never going to forget alpha-1 antitrypsin deficiency as long as I live. Of course, I'm not going to forget Charlotte Madison again either. But yes, sir.
Can anesthesias exacerbate bullying?
I mean, having anesthesia?
Extended, multiple.
Yes. I mean, but, anesthesia can be done well. And there are and there are many people that do it really well. So, I would do this with I'll just give you the same advice I give anybody, is that in general, you need to stay away from doctors and stay away from surgical procedures and everything else. You'll live longer. Yeah. Sometimes you have to see a doctor. And if you see a doctor, for God's sakes, take their advice unless they're stupid. It's really important. I can't tell you how many times people don't listen to what I say. I say, gee, if you do this, you'll be better. You'll be better. If I'm wrong, come back and say I was wrong, and I'll learn from that. I won't make it. But listen to your physicians about these sorts of things. That'll make a difference. Yes, ma'am.
Do you have a website?
I have a website. It went out again? Testing, 1, 2, 3. Okay, well, I'm sorry. So we have a website, but there are lots of websites you can go to. The website at University of Florida is www.alpha1.ufl.edu. There we post some of the stuff that we do. Again, I want to remind you that we're going to have show and tell tomorrow by my lab group, and they'll talk about genetic diagnosis and screening and stuff like that. You'll be tested at the end of the day for whether you're able to understand this stuff. So, any other questions? We're almost at the end, so I can take one more question. Is that right, Kathy? One more question. Yes, ma'am.
You said about doctors not looking at you. I had a doctor down here in Florida, but I'd already been diagnosed. He came in.
It wasn't me, though, was it?
No. But after him, I came to you. And he came in, he looked at me, and he said, "You don't look like an Alpha-1."
No shit.
I said,
I'm sorry.
I've never met one. And he told me that they were skinny and sickly looking. So I said, I must be fat and healthy looking. And he said, yes.
I think, as many people know, sick lungs don't show.
Thank you.
But I have to say, I contributed to to this problem. When I first started off, I described alpha-1 antitrypsin deficient individuals as skinny, as breathless, and young. And, I'm sure everybody's young at heart here. There are a lot of old folks here, too. So the bottom line is that we can't pick it out. And I'm working really hard to pass out that message. We're writing several papers that are coming out from the screening program that will come out during the summer, trying to re-educate physicians on knowledge that wasn't apparent 20 years ago. Thank you very much.